All right, let's jump right into one of the most terrifying and time critical emergencies you'll ever encounter in medicine: thoracic aortic dissection. This isn't just some textbook diagnosis, this is a flat out race against the clock. We're talking about a condition where literally every single second matters. Imagine a patient looking at you and saying these exact words. That phrase, ripping or tearing, it should set off massive alarm bells in your head. It's not just pain, it's a specific kind of pain that should make you think one thing immediately: dissection. This is the symptom that kicks off the entire emergency response. So here's how we're going to break this down. First up, what is an aortic dissection, really? Then we'll get into the all-important classification, types A versus B, which changes everything. After that, we'll go on the diagnostic hunt, explore the major fork in the road when it comes to treatment, and finally, talk about what the future holds for these patients. Okay, section 1. Let's get right to the nuts and bolts. What is actually going on inside the body's biggest blood vessel during this crisis? Okay, so this definition is, well, it's everything. The best way to picture it is this. Your aorta isn't a simple pipe. It's more like a high-tech, multi-layered hose. You've got a slick inner lining, a tough, muscular middle layer, and an outer wrapping. A dissection begins when a tear forms in that inner lining. With all the force of the heart pumping, blood starts to push its way into the wall itself, literally splitting the layers apart. This creates what we call a false lumen, a dangerous parallel blood channel where blood has no business being. So how does this whole disaster unfold? It's like a catastrophic domino effect. It starts with that one small tear, then bam, high-pressure blood rushes in, splitting the layers and creating that false lumen. But here's the really terrifying part. It doesn't just stop there. That tear can propagate, running down the aorta like a zipper coming undone. And as it travels, it can block off the crucial arteries that supply your brain, your kidneys, your gut, your legs. That state is called malperfusion, and it is absolutely lethal. So, to wrap up this first part, what's the big takeaway? A dissection is not a clot. It's not a blockage in the aorta. It's the wall of the aorta itself coming apart. This creates that dangerous false channel, which can kill you in one of two ways. Either the whole thing just ruptures, leading to massive internal bleeding, or that false channel squashes the real one and cuts off blood flow to your vital organs. Either way, it's a code red emergency. We know what it is. Now we have to figure out where it is. And I'm not kidding, this next part is maybe the most important piece of the entire puzzle. The location changes absolutely everything. So, there are a couple of ways to classify these things, mainly the Stanford and DeBakey systems. DeBakey is a bit more detailed about where the tear starts and stops, but in the heat of the moment, in the ER, everyone uses the Stanford system. Why? Because it boils everything down to one simple, critical question. Does this thing involve the ascending aorta, the part coming right off the heart? The answer to that one question decides the patient's fate. And here it is, the big dividing line. Stanford type A means it involves the ascending aorta, that part that curves right up from the heart. And that is a 5-alarm fire, a surgical catastrophe. We're worried it could rupture right into the sac around the heart, which is called cardiac tamponade and is instantly fatal. On the other hand, there's type B. This only involves the descending aorta, the part going down your back. It's still incredibly serious, but we usually start by managing it with medication. Telling A from B is literally a life or death distinction. So let's make this super simple to remember. Type A is for ascending. A great way to remember it is A for away to the operating room. It's an immediate surgical problem. Type B is just the descending aorta, and that's usually managed with meds first. This isn't just trivia. This is the central algorithm for this entire disease. You have to get it right and fast. Okay, so we have our suspicion. We know what we're looking for. So how do we actually prove it? This is the diagnostic hunt, and trust me, the clock is ticking loudly. The whole thing starts at the bedside. You're listening to the patient's story, that sudden, awful, ripping pain. But then you have to actually examine the patient, looking for clues. Is the blood pressure in one arm way different from the other? Can you feel a pulse in one foot but not the other? Do you hear a brand new heart murmur that wasn't there before? Any one of these things, and your suspicion level just went through the roof. To make sure we don't miss this, we've got tools to help us, like the Aortic Dissection Detection Risk Score, or ADDRS. It's really just a way to organize your thoughts. You look at 3 categories. 1. Does the person have a condition that puts them at risk, like Marfan syndrome? 2. Is the pain the classic type, sudden, severe, ripping? And 3. Are there any of those scary exam findings we just talked about? If you tick a box in more than one category, that patient is high risk and they are going directly to the CT scanner. No delays.
And this is what we're looking for, the money shot. This CT scan gives us our definitive answer. You see that little line, that flap inside the aorta? That's it. That's the torn inner lining, dividing the aorta into two channels, the true lumen where blood is supposed to be, and that dangerous false lumen. This picture is undeniable proof. We have our diagnosis.
So you see the pathway, right? It's a clear workflow. Start with your clinical suspicion, back it up with a risk score, and then get the final answer from the CT scanner. And remember, that CT is crucial because it doesn't just say, yep, it's a dissection. It tells us the most important thing. Is it type A or type B? And what other trouble has it already caused? And that leads us right into section 4, treatment. Now that we have the diagnosis, what do we do about it? Is this a job for a surgeon or is it a job for medication? Well, the answer depends entirely on what we just saw on that CT scan. Let's put ourselves in that situation. The radiologist calls. It's a confirmed aortic dissection. What's your very next phone call? Are you calling the operating room to get the surgical team ready, or are you calling the ICU to start some powerful IV meds? And here is that fork in the road we've been talking about. If that CT showed a type I dissection, it's not a discussion. It is a full-blown surgical emergency. The only goal is to get that patient into an operating room and replace that torn piece of aorta before it ruptures. That's it. But if it's an uncomplicated type B, we take a totally different path. We go into full-on medical management mode. The plan is to get that patient to an ICU and slam the brakes on their system, lower their heart rate, lower their blood pressure, and just reduce the stress on that damaged artery. Now, for this medical management, there is one rule you absolutely cannot break. It's called anti-impulse therapy, and the order matters a lot. Step 1, control the heart rate. We use IV beta blockers to slow the heart down. Think of each heartbeat as a hammer blow on that tear. We want those blows to be slower and softer. Step 2, after the heart rate is controlled, then we bring down the blood pressure. Why is this so critical? Well, if you drop the blood pressure first, the body will reflexively speed up the heart to compensate. And faster, harder heartbeats are the last thing you want. You could literally make the dissection worse. So remember, rate control, then pressure control. Always. Okay, so let's recap treatment. It's pretty black and white. Type A means surgery, immediately. Uncomplicated, type B means medicine, with that all-important rule, rate before pressure. Now, there is a gray area. What if the type B gets complicated, meaning it starts to leak or rupture or cut off blood flow to an organ? Well, then it needs an intervention too. Often that's something called a TVR, where a stent graft is placed from inside the aorta to cover the tear. All right, last section. Let's talk about the aftermath. What are the immediate dangers we're worried about? And for those who make it through, what does the future hold? Probably the number one thing we fear is malperfusion. Basically, that flap of tissue from the torn aortic wall can act like a curtain. It can fall over the opening of a major artery branching off the aorta. Sometimes it just gets stuck there. That's a static obstruction. Or even worse, it can flap back and forth with every heartbeat, cutting off blood flow intermittently. Either way, you're starving vital organs of blood, and that's a disaster. Let's just stare at this number for a second because it really tells the whole story. For a type A dissection that goes untreated, the mortality rate goes up by 1 to 2% per hour. Think about that. Within 2 days, half of those patients will be gone. This is why there is no let's wait and see. This is why we run. This is one of the deadliest conditions in all of medicine. Which brings us to one last critical question. If a patient gets through the surgery, they survive the ICU, are they cured? And the answer is a hard no. The immediate crisis is over, but the aorta itself is forever changed. It's now a weakened, scarred blood vessel. This isn't just a one-time event. It's the start of a lifelong condition. These patients need their blood pressure controlled perfectly, and they'll need regular scans for the rest of their lives. Surviving the dissection is just the first step. The vigilance never really ends.